Reproductive pathology is a fairly large section, and there's obviously a lot of high-yield material here. What you'll see early on is a lot of integration with reproductive anatomy and physiology, and later on with neoplasia from the pathology section. So definitely make note of these correlations as you study through the section. So let's start with sex chromosome disorders, which we tend to see hit pretty hard on step 1, so they're definitely worth spending a little time on. Klinefelter syndrome occurs in males who usually have the 47XXY karyotype. So where do you get the extra X chromosome? It usually occurs when paired X chromosomes don't separate during meiosis and oogenesis, or when the X and Y chromosomes don't separate during spermatogenesis. In other words, they are examples of non-disjunction. As in normal females, one of the X chromosomes will be inactivated as a Barr body. In terms of presentation, Klinefelter's patients are tall, long-limbed, developmentally delayed, feminine, infertile males with gynecomastia. In a question stem, you might actually confuse them for Marfan's at first glance, but the secondary sexual characteristics give it away. You can see some of the feminine features here. Also in these features you can see a little bit of gynecomastia. One of the major sequelae is that they have testicular atrophy, which leads to dysgenesis or defective development of seminiferous tubules. They have no Sertoli cells to make inhibin, so you get no negative feedback on the FSH production. What this all means is that you end up with high FSH, which is one of the major tests you can do for the disease other than direct karyotyping. The abnormal Leydig cells will also produce less testosterone, leading to increased LH, along with increased FSH. This leads to an increase in estrogen, specifically estradiol. It's the increased estradiol to testosterone level that leads to gynecomastia. It also puts these patients at a much higher risk of breast cancer. Now let's discuss the other major sex chromosome disorder, which is Turner syndrome, a disorder where females have the genotype XO. Again, this is another example of non-disjunction, where the sperm or egg is missing the X chromosome prior to fertilization. To remember, XO is the genotype for Turner syndrome. Some people like to use the mnemonic hugs and kisses XO from Tina Turner. Why not, right? In terms of disease phenotype, patients with Turner syndrome are short females with a shield-like chest and webbed neck secondary to poor lymphatic drainage. The neck mass is referred to as a cystic hygroma. Here's another patient with Turner syndrome, and you can see the webbed neck here and here. Because of the XO genotype, patients are missing a copy of the SHOX or SHOX gene, which is responsible for long bone growth. This explains why they're so short. Another clue is if the patient has preductal coarctation of the aorta. Most coarctations occur downstream with respect to the ductus arteriosus, but Turner syndrome patients get them upstream. Make sure you remember this because it's a frequently tested feature of the disease on step 1. Some other things to keep in mind are that these patients have non-functional streak gonads, and therefore a decreased estrogen level, along with an increase in LH and FSH, which results in primary amenorrhea. So what's the difference between primary and secondary amenorrhea? Primary means that they've never had a period, whereas secondary means that they've had normal periods in the past, and that now they've stopped. If you get a question asking about primary amenorrhea, you absolutely have to think about Turner syndrome. Other things to think about include Mullerian agenesis, or anatomical abnormalities like imperforate hymen or vaginal septum. The only other chromosomal abnormality you might see is the double Y male who has the genotype XYY. Unlike males with Klinefelters, they have normal fertility, though some studies link this genetic abnormality with increased aggressiveness. This is a very high-yield table in first aid that will help you separate the major sex hormone disorders. The key here is to focus on LH and testosterone values, which are often given in the stem of the question. In this context, also keep in mind that from our discussion in the last section, LH stimulates testosterone release. You also need to think about responsiveness to the hormones because, after all, a hormone is really just a messenger. A patient with a defective androgen receptor, for example, would be unresponsive to androgen. Thus, through lack of inhibition, LH and testosterone would be upregulated, and yet they would have no effect. The primary example of this is androgen insensitivity syndrome, which we'll talk about in a few minutes. Another example would be a patient with a testosterone-secreting tumor, or a patient who is using exogenous testosterone, who will have high testosterone that will decrease LH by negative feedback. Therefore, these patients will have high testosterone but low LH. Next, primary hypogonadism is a condition where the gonads do not function properly and do not respond to LH. Thus, LH will be high since the body is trying to stimulate the end organ to secrete testosterone, but testosterone will be low since no matter how strong the message is, the effector organ just can't comply. In hypogonadotropic hypogonadism, the defect is typically with the hypothalamus or the anterior pituitary and not the gonad. You basically see low LH and FSH levels leading to low testosterone, since in effect the gonads aren't receiving any message from the hypothalamus. So you get this hypo-hypo picture. An example of this is Kallman's syndrome, which we'll discuss in a minute. The next topic we'll talk about is sumohermaphroditism. The word hermaphrodite comes from Greek mythology. Hermaphroditus was the child of Hermes and Aphrodite, and this child had features of both males and females. See, not only does knowledge of the Greek and Latin languages help you out, it even pays to know the mythology. Basically, pseudo-hermaphroditism is the disagreement between phenotype, i.e. the external genitalia, and gonadal sex. Female pseudo-hermaphrodites have the genotype XX. They have ovaries, but their external genitalia are ambiguous or more male-like. One way this happens is that during their fetal development, they may have had some exposure to exogenous testosterone. They could also have been exposed to endogenously produced testosterone from congenital adrenal hyperplasia. Male pseudohermaphrodites have the genotype XY. They have testes, but the external genitalia are female or ambiguous. Again, the big example is androgen insensitivity syndrome, or testicular feminization, which we'll discuss in a bit. True hermaphrodites are rare, actually, and have both ovaries and testicular tissues, otherwise known as ovotestes. Because of this, they have ambiguous external genitalia. So as promised earlier, now we're going to discuss androgen insensitivity syndrome. Androgen insensitivity syndrome is where you have a genotypic XY male with a defect in the androgen receptor, so you end up phenotypically looking like a woman. The testes also secrete some estrogen, which is unopposed in the absence of testosterone's effect. So as a result, these patients develop normal breasts, a normal lower vagina, and normal clitoris. However, they don't end up developing a uterus, cervix, upper vagina, or fallopian tubes. So why is that? That's because the testes are still making anti-Mullerian hormone, or Mullerian inhibiting factor. All this results in a normal-appearing female with female external genitalia, but with a blind-ended vagina and no uterus. Here's a picture of women with androgen insensitivity syndrome. Again, they are male by genotype, but externally you can't tell them apart from other women who are XX. Here's another good disease to know. Remember that 5-alpha reductase is the enzyme that converts testosterone to the much more potent dihydrotestosterone. Without the potency of DHT, these XY males will have ambiguous genitalia until puberty, at which point you get a significant increase in testosterone levels. In some cultures in which this condition is more common, patients are raised as girls until puberty, at which point they transition into a more male role in society. In terms of biochemistry, the level of testosterone in these patients tends to be normal. The LH level may be increased. The only other thing to keep in mind is that, like most enzyme deficiencies, this is an autosomal recessive disease. As I mentioned earlier, Kallmann syndrome is an example of hypogonadotropic hypogonadism. This is a board's testable topic because it demonstrates what happens when the hypothalamus fails in sexual hormone regulation. Kallmann syndrome is a defect in the brain caused by improper migration of GnRH-secreting neurons during development. Low GnRH causes decreased synthesis of gonadotropins in the anterior pituitary. This leads to low FSH and LH levels, which in turn leads to decreased testosterone and sperm count. You also see low estrogen levels. The result is delayed or no puberty and a lack of secondary sexual characteristics. Females won't menstruate and won't have normal breast development. Males might end up with a micropenis. The defect in the brain is also located in an olfactory center, so these patients also have anosmia, or the inability to smell. So if a patient can't smell and has a lack of secondary sexual characteristics, or amenorrhea, think Kallmann syndrome. The anosmia is a good way to keep it straight when you have to decide between this disease and several of the other disorders of sexual development.